The opinions expressed on the following sponsored program are strictly those of the host, guests, and callers, and not necessarily those of this station, its staff, management, or sponsors.
Cutting Edge with Anita. Our radio show features cutting-edge, fascinating topics with fascinating people from medicine to lifestyles. Now, here's Anita.
Okay, we're here with Cutting Edge with Anita, and we've had such a fascinating conversation here with Dr. William Leone, who is the orthopedic surgeon supremo, I will say that, and welcome to the show, Dr. Dr. Leone. I'm really happy that you're here this morning.
Good morning. I'm really honored to be here.
Well, this is a cutting edge show. We always try to bring people on who do things. It's kind of ironic when you're a surgeon that it's a cutting edge show, but that was the whole thing. I've had people from all over the world, as a matter of fact, on this show because I try to search out things that people don't know about. And there are so many cutting edge opportunities, whether it's in medicine or in entertainment or I had Ed Mitchell, the astronaut. I mean, people who are really, sitting around doing things with their mind that's for the next 50 years we're going to be learning about these things, and we try to catch them right now. So, Dr. Leone, I have a great personal experience with you because you have been such a wonderful orthopedic surgeon for my husband, Bill, and we appreciate that very much. But you don't just sit around. I know you do a lot of surgery, but you also are an inventor. And how did that all happen?
My practice really focuses on very complex and reconstructive hip and knee problems. And when one does a total hip replacement, which I do a lot of, a key to really getting an optimal, consistent result with equal leg lengths and allow someone just to live their life is getting the two parts in just the right orientation and the right position. And without question, the most difficult part is getting the cup right. And a lot of surgeons, a lot of hip surgeons recognize that that's still the number one problem in hip replacement surgery, getting the cup, getting the acetabular component in just the right position.
So let's move back a little bit for people who don't really know what you're talking about,
okay,
who are listening. Let's talk about what happens now, what a cup is and what you have to do. Someone comes into you and they have a hip problem. Oh, my hip's killing me. Tell me the procedure of what you do.
Well, a lot of people think it's their hip, and in reality it's not their hip. They pulled a muscle on the side of their pelvis, or it's coming from their back, or maybe they just strained something. So it really starts out with a real history, an old-fashioned real exam, not just ordering an x-ray and MRI scan. I can learn so much from a plain x-ray without an MRI scan. We do so much of that's just not necessary. And then making a diagnosis, recognizing, identifying really what the source of the problem is. If indeed it's coming from an intra-articular problem, that is not a problem from outside the joint, from within the capsule, from within the joint, and many times it involves a wearing away or degeneration of the two parts of the bones that rub together, the ball moving in the socket, and the cartilage, the lubricant is worn away, or it's fissured, or it's cracked, and the bone is reacting, then that's the kind of condition that progresses as a natural history. And at some point, you try all the conservative things and you say, I'm not happy. I can't sleep. It hurts to stand. I'm beginning to limp. I'm avoiding the things I like to do, be it walk my dog or play with my kids or plant an orange tree. So at that point, if you treat that with a hip replacement, that is replacing the ball with an artificial one and replacing the inside of the socket, if done well, and if someone's goals are realistic, i.e. they don't want to have pain, they want to walk normally, they want to go play maybe golf or tennis with their friends, then there's a very, very, very high probability that those are realistic goals. But the problem comes, how do you get the parts in just the right position? And because I do so much of this, and it's clearly recognized as the number one problem, getting the cup right, I began to recognize that the assumptions that doctors have to make, they have no choice but to make ultimately when they implant the component. The assumptions can't be quantitated or qualified. They can't be corrected for. To put it simply, we take our best shot at it. It's a very educated guess, but it's a guess. So how can you take something now and not guess? How can you measure it and make it reproducible? And that's what my invention has done.
So how can we? He has, I wish for our audience, this was on television, you could see the smile on Dr. Leone's face. It's like, he's like a little kid in a sense that he decided, he was going to do the best that he could. I've been told by his staff he's a perfectionist, and everything he does, whether he flies his plane as a perfection or runs his boat, whatever he does, has to be the best. And so now you came up with something because you wanted your patients to walk away literally, with the best hip replacement they could have.
Exactly. So when a doctor tries to place the cup in the pelvis, they have certain very specific goals regarding angles that the cup ultimately needs to be in relative to the ground when their patient is walking. And we assess that instantaneously after we take an x-ray. So, but the conundrum becomes, how do you put this cup in someone's body when the body's moving, when the body's deformed from the arthritic process, or interestingly, more times than not, the most common reason why someone needs a hip replacement is because they develop a condition called osteoarthritis. There's other conditions, but that's certainly the most common. And what's happened in my 23-year career is we've become much, much more sophisticated in recognizing what caused the osteoarthritis. It's not just a genetic thing. There can be a genetic predisposition, but about 90% of the time, the osteoarthritis is really due to some underlying biomechanical abnormality. They have too much coverage. They don't have enough coverage. There's a degree of dysplasia. There's too much rotation. And so all of a sudden, as we've become better at it, we recognize what led to it, and the whole real key to getting a perfect result is recognizing what led to the problem and not just resurfacing it, but correcting the underlying biomechanical abnormality. So with this very intuitive, simple device, which I created not to create because I needed something, I recognized there was a problem, I can now really measure very reproducibly in the OR how a patient's pelvis moves from where I think it needs to be in the beginning, and I can use just standard instruments that every instrument set in the whole world has with every company. I can measure, is this 40 degrees, is this 45 degrees, how much forward flexion, and also what it now allows me to do is absolutely measure the parameters that patients perceive with leg length equality, i.e. how long it is and how much offset. So you can then, after you do the reconstruction, you can go back and critique it. You can say, is this as optimal as it can be? So what it does is it takes everything we do in life, if we're trying to shoot for a bullseye, there is no such thing. But you can take something now and make the clumping around the bullseye much, much tighter, and you can get rid of those outliers where the problems really occur. And that's the key.
Well, thank you for that explanation, because how many of us have been with friends, and all of a sudden, someone's had a hip operation, and they said, yeah, well, I'm still limping a little bit, and it's not perfect, but it doesn't hurt, it's still better, right? That's not good enough, is it, for you?
Joint replacements, particularly hip replacements, are a remarkably predictable way to get rid of pain, but to really have the hip just feel like a normal hip and just get on with all the activities of life that make you smile and you want to be engaged in, you also really have to tweak the mechanics, the biomechanics, and recreate what optimally needs to be there. The right tension on the muscle, the right offset, the right relationships. And that's an art. It's really so gratifying because people come back and say thank you.
Thank you. I'm sure they do a lot more than that. I of course told Dr. Leone so many times that everyone who has ever seen Bill and knows that he's just he's a Mr. Bionic guy now because he's had knees and hips. But he's perfect, and he's going to be 89, and he's perfect. And I attribute a lot of that to Dr. Leone, actually. And so we are very grateful to you.
Well,
and really,
your Bill is one of those special guys that flew bombers in the war and writes novels, and he's one of those guys that guys want to be like. He's a remarkable guy.
But if he didn't have a remarkable physician, no, seriously, if he didn't have someone, he could be, and he'd figure out how to be a wheelchair-bound person or a person that limps. But it's so nice that he's so straight and tall. In fact, after he got his knees and his hips, he actually grew. Did you know that? He actually got taller. That's what he said, because...
Yeah, but the goal was not being taller on one side.
No, that's right. He hasn't taller on one side. But let's just go back to this. I want to talk to you personally about yourself. When did you know you wanted to be an orthopedic surgeon?
Oh, goodness. When I was a little boy, my father's a doctor, and he just turned 90. I knew I wanted to be like my dad, so I wanted to be a doctor. And I didn't really know what it meant. And then I recognized what I was really good at was sculpting and art and anything three-dimensional and seeing things, doing it with my hands. So I knew I wanted to be a surgeon. And when I was at Emory Medical School, I got to do a rotation with the orthopedists because I thought I wanted to be a hand surgeon. And the orthopedists were having the most fun. And I said, boy, I can do this. I can definitely do this. So then I decided then I was going to be a hand surgeon. But I met a wonderful man when I was a second year PGY1 at Jackson Memorial doing my residency, or my first or second year of orthopedics, a guy named Gordy Hill. And he had this outrageous practice, and people came from all over the world, and he was truly a maestro. And there was a logic to why he did what, and it really goes with what I do. And so I learned a long time ago that if you meet someone, even if they're not doing exactly what you think you want to do, but you can learn their style and you can learn their thought process, how to solve a problem, then you need to pay attention and learn. And before I knew it, I was taking over Dr. Hill's practice. So that was a long time ago.
Good advice, because Bill's first hip was with Dr. Hill.
Right.
Right. That's very funny. I didn't realize that. Is it true that he is the one that came up with the special kind of glue or something, the cement or whatever was? I thought that he invented something like that.
No, but he was such a pioneer in the field that when he was one of the very first few in the country to begin doing hip replacements in the early 70s. And there's a gentleman, true genius, who gets the credit for being really the father of modern day, not just hips, but modern day arthroplasty, hips, knees, shoulders, and he recognized certain things that allowed the field to develop into what it is. And this is Sir John Charnley, and one of the things that he recognized was that he could use a acrylic, he could use what some people refer to as glue, which is a complete misnomer, or bone cement, which is also a misnomer because it's not really cement. It's really a grout, an acrylic grout called methyl methacrylate. And if he used that to fix the parts to the body, then predictably, for many, many years, they would be stable. And that's one of the things that he introduced. And so what Dr. Hill used to do, at least the story goes, is we couldn't get in this country, and they would smuggle these white bags in from Canada of bone cement. And of course, nowadays you'd go to jail for that. That was a long time ago.
My guest is Dr. William Leone, and he is an orthopedic surgeon. He's out of Holy Cross Hospital. Actually, he has a whole center named from him, the Leone Center at Holy Cross Hospital. And I have to tell everyone, if you like what you're hearing, he's going to be one of our prestigious speakers at the go ahead, you can tell me what.
No, that's okay.
Oh, no. I mean, he's going to be one of our prestigious speakers at the Cure Symposium on October the 13th. I hope everybody making that phone call, 561-736-8000, to get your tickets. And we look forward to seeing you there. But this is the quality of what we are bringing to help you understand more about your body and your mind and what you're doing. Dr. Leone, in continuing this, I just wanted to ask you, though, when you said that, when you do surgery for someone, and what is it that makes one person after 3 days walk And some people, for 2 weeks, they're still not walking, or they're, I mean, even if your surgery was a success, is it just their bodies are different? What makes the difference?
People refer to the orthopedists as bone surgeons, and there's this reputation as great, big, huge guys, and it's such a misnomer. It's such a soft. It's all about being extremely gentle, being extremely precise and meticulous with tissue planes and with hemostasis, that is bleeding, both with hips and knees. So I think a huge reason why my patients get well so quickly is because, first of all, they go in with a lot of knowledge. I personally spend time with people. My staff spends time. There's a kind of a pre-operative orientation at our hospital, Holy Cross, where the nurses and the therapists, so they go in with a lot of insights regarding what's going to happen. And that in itself is therapeutic because the anxiety level has been brought from 10 way down. We do a lot of things different now. This is probably one of the greatest changes over the last couple of years to diminish pain, because pain can stop anyone in their tracks. And so if you begin to prevent pain, and your whole strategy is not to let it get out of hand before you're catching up, and then recognize that pain is coming from many different modalities, and you treat the different modalities versus just give someone morphine, which makes them feel sick, then you don't lose the first 1 or 2 days. They're out of bed, having breakfast, walking the first day. And it's not only psychologically important, physically, it's just so important. You get well quicker, and you prevent so many of the complications. I think the therapy is important, but, honestly, hip replacements that are done well, they just do well. Partial knee replacements that are done well, they just do well. Total knee replacements, they do need more therapy. But again, if your strategy is to prevent swelling, to prevent bleeding, to have wounds that are closed meticulously, not with staples, but like a plastic surgeon, and not have big binders on the knee, then it doesn't hurt, and people do well. So it's not a mystery. It's all about really recognizing the components, and the tissues have to be balanced, and you have to be very, very gentle with tissues. That's the whole key to this.
It's interesting you should say that, because I go to a great dentist, someone who is so meticulous and so carefully does a lot of the things you were talking about, and he always sends me home with a prescription for pain medication. I never have to use it, and I've had some major dental surgery, but he's just like what you were saying. Since I've not had knee and hip surgery, I can't discuss what you've been doing except through Bill. But you're absolutely right. It's in the process. If you really know what you're doing and you apply the very best medicine, I think it does make a difference.
I always give patients a prescription of some pain medicine to go home from the hospital. But I'll often tell them you probably won't even need to use it. But this way, you don't have to worry about it. You know you have something if you do. And that in itself is therapeutic.
Okay, and it seems now that you also, do you like doing hip or knee surgery better? I know you do both.
Goodness.
That's a big question.
I just love the feeling of accomplishing either and knowing that my patient's going to do well, and technically it's perfect. And I love that feeling of walking through these double doors as I exit the operating room to visit a family, and they watch my body language and they see my smile, and I can look them in the eye and hold their hand and tell their family very honestly, it's really well done. It's perfect mechanically. It's just right, and I think they're going to do fantastic. And so whether it's as a surgeon, as a physician, as a human being, we all want to really solve a problem with the least energy and the least invasiveness that we can, but to really solve the problem. So if you can really solve a knee problem with an arthroscopic surgery, it feels good. If you can really solve that knee problem only by replacing one compartment, i.e. the medial compartment, the inner compartment, or the outer compartment, or just the compartment underneath the kneecap and the femur, and that really solves their problem, then it feels great. Or if they have a horrible knee and they've had 10 or 15 prior surgeries and it's all deformed, and you can really take that knee and now make it not only look straight but be mechanically balanced, and they can move it and they can get on with their life again. It feels great as a human being.
Yeah, I'm listening to you, and I picked up on something you said, because there's a difference of someone whom you are going to first operate on and someone who you're doing a revision on, and you may want to talk about those differences.
You know, I'm so blessed because I just take care. I have a fantastic practice, and I really take care of nice people, and I really created the reputation that I have over 23 years by really being that person in this part of the world that would take care of all these people that nobody really either wanted to or could. Infections and the congenital stuff, and someone who's had a hip or knee replacement once or twice or 3 or 4 times before, and what's the next step to try to take what you have left. So I really developed skills as a revision surgeon, and if you can do the really hard revisions and really understand then how to create constructs that are really stable and do fancy things with bone grafting and with tissue, then it makes the other stuff, it gives you so much more insight. It gives you to see nuances that makes the other stuff just easy and that much better.
Yeah, that's a very good explanation. So many people are talking now about stem cells, and what are we going to do? You know, so many. I think before Bill finally went and had some of the knee work, he said, "Can I just inject cartilage in my knee?" and so he couldn't wait for that to happen. What do you think the future's holding?
I think we're at the very, very, very early beginning stages of something with a lot of potential, and I think right now we can suck some blood out of our bodies, spin it down, get the platelets that happen to have other things in it, inject it in places, and kind of pray that it's going to actually do something. And sometimes it does, because there's a lot going on in there that, in terms of healing factors that we're just learning about. I think it's at the early stage. I think you have to know its limits. I think everyone who has a back problem now ends up with a pain management doctor. We didn't even have pain management doctors 10 years ago. Now everyone has one. I think more and more of the knees I do, before they have their knees, they've done all sorts of things which biomechanically couldn't work, but now that's something we're offering on the menu. And I do certainly applaud and agree with that you need to try all the conservative things before one capitulates, and I do what I do in the OR. But there are also times when, in the case of a hip, if the ball's flat and you've got big spurs, or in the case of a knee, when you've got gross bone on bone and now an angular deformity or a contracture, that injecting whatever kind of fluid in that knee is just not really common sense. It can't fix that.
Well, you said that your father is going to be 90, or he is 90, and I remember years ago that when someone was even in their late 70s, to perform some major surgery was, well, you know, how long are they going to live? And I recently had a physician on my show, and I think it was a cardiologist, and I said, what is the age of the oldest person that you have? I think he may have been a thoracic surgeon. And he said, oh, it was 97. And he said, as long as they're in good health, you know, other than this, they can do it. So has age now is not a factor?
You know, in my practice, age has never been a factor. Certainly, I've seen this remarkable trend from when I started. I was always so impressed if I was operating in someone who was 80, and now even 90 doesn't really impress me. I take care of lots of people, even if I don't want to have something done in their 20s, or certainly their 30s and 40s, lots and lots of people, because people don't want to live with pain, and it's a different mentality of the old days where you're going to fuse it or you're just going to suffer and end up in a wheelchair. Americans aren't going to do that. People aren't going to do that if they don't have to. I wouldn't. So certainly the trend is not only getting older but younger, and absolutely my philosophy is it's all about, it's not the chronologic age, it's the physiologic age, and it's understanding these are the cards, and let's at least be realistic and define what the risk factors are. You're 85, you're 90, you have coronary artery disease, you've had a heart bypass surgery, maybe you have a valve. These are, how can we now at least define them, and to the very best of our ability, manage them, because we can't change certain things. Or maybe we can change. Maybe you can get their blood pressure, the diabetes in better shape, or they can lose some weight, or they can do something. And then part of my success truly has been that I work I work in a part of the world where there's so many incredibly good people that have insights and skills that I don't have. I work at a hospital, Holy Cross, which, honestly, if you're going to have this done, it's where you want to be, because there is such a system, and we do so much. And when you say you do so much, it means that you're not recreating the wheel. Everyone knows their part. This is not a new rodeo, and that's good. You keep tweaking it versus creating it from anew. And you have a medical staff which just has depth. God forbid someone has a heart attack or a stroke, or they have a bellyache, or they whatever it is, or they need a great pulmonologist, or they're gonna they have this genetic propensity to grow large spurs or bone in the tissues after surgery called heterotopic ossification. I can treat these things even before and anticipating it with radiation. So having a real medical center with a tremendous depth to the medical staff really allows me to do what I do.
You are so generous with your compliments to everybody. And of course, you're really the heart and soul of this. Wow. And then they all kind of move around you. Before we run out of time, I just wanted to ask you, so today, if someone has a hip replacement or a knee replacement, how many years can they expect to keep that?
Well, that is...
That's my last question, right? I'll probably take another half an hour, but try.
It's a wonderful question. It's an appropriate question. It's a question I think everyone should ask. And it's a question that, because we keep changing variables, not only in technique, but mainly in prostheses and patient choice, it's hard to put a real number on. I can tell you that people who had their hip or their knee replaced 15 or 20 years ago, and they were replaced with prostheses of that day, as history would bear out, that were not outliers, they were good ones, and they were replaced by people, surgeons, that really do it. They were well done. There's about a 90% chance 15 or 20 years later they're still functioning, and they're failing about 1 to 1.5% a year. So the real question is, what's changed in 15 or 20 years? I can tell you that our techniques, just in terms of mechanically doing the surgery, are so much more refined. They just are. And I can tell you that on a molecular level, the bearing surface, the actual parts that rub together, are a magnitude better than what we had 15 or 20 years ago in terms of our insights, and how we improve the ultra high molecular weight polyethylenes with radiation, and then getting rid of the oxygen free radicals, and how the plastics lock to the substrates, and how so it keeps getting better. And it's very heartening. It's a good thing. It's a really good thing that when you look at all of these top orthopedic companies, 5, 6, billion-dollar companies, it's great that they're all basically doing the same thing. They're all saying that they've got the holy grail and they've got the best, but the reality is all of them are so much better than what we had. So if you took care of someone in their 50s or their 60s, can you really say that this can last 20 years? Yeah, you can. You need to be responsible. I wouldn't recommend. They say, well, what can I do after this surgery, doc? I say, the reality is you'll be able to do everything. But if it was me, let me tell you what I wouldn't do. I wouldn't run marathons, just why beat it up. And I'd probably stay away from all the really high impact, like, they play full baseball. Right. But people do what they're going to do.
Well, with that, I want to thank you very much for being my guest. And Dr. William Leone, who is a real hero in the world of orthopedic surgery. And I do have to tell you that the Cure Symposium, one of our major sponsors, is Stryker, which is a very, very fine company that does it. They're Medtronic. Jaguar is a sponsor, as well as Walgreens and United Healthcare. So we feel very happy. We hope people will come. Remember, 561-736-8000. Let me give you, if you would like to get a hold of Dr. Leone, you can reach him at 954-489-4575. 489-4575. Thank you so much, Dr. Leone.
Program were strictly those of its hosts, guests, and callers, and not necessarily those of this station, its staff, management, or sponsors. It's smart to be smart about your medical health.